My name is Andrew Grossman. I have an MD degree from New York Medical College, and I'm board certified in emergency medicine. I also have a general practice in the Melbourne area. I spent most of my time in different places working in ERs. Most of my life I spent 15 years as a medical director. Now, since 2017, has been lowered. The threshold for hypertension has been lowered. And because of that, the incidence of hypertension in this country has increased from 32% to 47%. So 47% of the population in this country is labeled hypertensive. Once a person has crossed that threshold with respect to blood pressure, they now have higher risk for some of the more common disease entities such as coronary artery disease, congestive heart failure, atherosclerosis, diabetes, strokes, ischemic strokes, which ischemic means a non-bleeding stroke, and also bleeding strokes, where there's bleeding into the brain. And this is the reason why we have lowered the threshold since 2017. It used to be 140/90, and was the bottom rung of hypertension. Now it's become a lot lower, 130/80. And these blood pressures are now taken at home, where the patient or the potential patient is more relaxed. There's a certain way to take the blood pressure, and it needs to be taken while you are relaxed and sitting up. Ideally, you need 5 minutes sitting and relaxed before taking a blood pressure. And we generally take the average of the blood pressures. In the office or in the emergency room, blood pressures tend to be falsely elevated, and that is because of the anxiety factor, which is very common in the emergency room and not as common in the office. However, there is this entity called white coat hypertension, which is due to patients seeing a white coat or seeing professionals. It causes them to be a little anxious, and that causes the blood pressure to be falsely elevated. In the office, hypertension is 140/90 and above, but at home it's 130/80. And anything above that is considered hypertensive. We find that the blood pressures are higher in a professional setting than they are at home in a relaxed setting. When we see that there's a tendency for hypertension in the office, when we see that the blood pressures above that threshold, we suspect it. At that point, unless there is symptomatology or unless it's an urgent hypertensive urgency or emergency, a patient is generally asymptomatic. We don't treat it right away, but we send the patient home with instructions on how to take his or her blood pressure at home. There are internal causes and there are external causes. Internal causes include underlying causes that are not changeable, would be familial tendency or propensity, genetic. There's a genetic predisposition for hypertension. External causes would be environmental factors that may cause stress or lack of sleep, anxiety, general anxiety, which comes with stress. Certain medications. There are medications for obesity, over-the-counter medications, such as decongestants, and medications that are prescribed for other reasons, other purposes. Some of the obesity medications can cause hypertension. And of course, antidepressants and some antipsychotic medications will cause hypertension. Some of the NSAIDs, not necessarily Motrin or naproxen, but others can cause mild hypertension. Diet and is a very important contributing factor for hypertension. The amount of sodium that you take in, obesity. There are different medications that are used. The most common medications that we use now are the calcium channel blockers, such as diltiazem, and the ACE inhibitors, such as Vasotec. And a similar medication to an ACE inhibitor would be an ARB. Losartan is an example of that. And these medications, the ARBs and the ACE inhibitors, work on the kidneys to regulate the blood pressure in a more physiologic way to open up the vessels of the kidneys and allow kidney perfusion, better filtration of the kidneys. Diuretics, especially the non-thiazide or the thiazide-like medications, such as chlorthalidone, are used. And when they are used in conjunction with the diuretics approach from a different angle, so now you have diuresis and you have direct lowering of blood pressure, and the two together work much better than one medication alone. Most patients start on one medication, either a diuretic or a direct antihypertensive agent, and then they often are increased to dual medication, usually including an ACE inhibitor or an ARB, a calcium channel blocker, and a thiazide-like diuretic medication. Most people unaware of their hypertension. When it gets high enough, sometimes there are symptoms. There may be neurologic symptoms. Headaches are probably a lot less common than you would think as a result of hypertension. Most of the symptoms are nonspecific. What constitutes a hypertensive emergency or urgency is extremely grade 3 hypertension, extremely high blood pressure, like 200 over 120 would be something that you want to lower even if the patient is asymptomatic. Most of the time, the urgency or emergency is related to the symptoms that are tied into what we call end organ damage, such as chest pain, shortness of breath, encephalopathies. These constitute a hypertension urgency or an emergency where the patient's blood pressure needs to be lowered. We don't lower them as aggressively as we used to because there are side effects from lowering blood pressure too fast. There's a difference between treating hypertension in an office setting as opposed to hypertension in an emergency room or urgent setting. We treat in the office to prevent the sequelae that occur over time. If a patient is hypertensive or over the threshold, we start to see peripheral vascular disease, coronary artery disease, atherosclerosis, possibly diabetes, strokes. And so to prevent these things from happening and to keep a patient healthy, we begin to treat the blood pressure slowly. First we treat with diet, with behavior modification, environmental modification. Counseling is very important. A low sodium diet. We want to restrict sodium to 2 grams a day. And the way we do this is by knowing the amount of sodium in what we eat. If not that, then you want to stay away from artificially canned foods. A canned soup, not something that a hypertensive person should consume. So we want to work with the diet. And then people who are active as opposed to people who are inactive. Inactive people tend to have higher blood pressure. Active people, that has a good effect on blood pressure. It tones the blood vessels and the body so that the blood pressure comes down. So we want to have patients exercise a certain number of hours a week. Moderate exercise is fine. Well, it's very important for us to monitor our blood pressure and keep it below the threshold. Counseling is very important. And it's important for me as a physician to help you to understand the behavioral modifications and the diet requirements and activity requirements to help to lower blood pressure in a healthy way. If the blood pressure doesn't come down enough, there are medications that a patient can take that we can prescribe to you. Can I take a sip of coffee? Or?
Absolutely.